So this is Dr. Carl Cohen. He is the Division Director of Geriatric Psychiatry at SUNY Downstate, as well as Distinguished Service Professor. He has won multiple awards for his work in late life schizophrenia and also as an educator nationally, as the author of well over 100 peer-reviewed publications, several textbooks, and I think has been a mentor to all of the faculty on this call, and we're very grateful for his talk today.
All right, well, thank you very much. With that nice introduction, I'm certainly anxious to hear what I have to say. Let me go back, and the topic, as you can see, is emerging perspectives on outcome in older adults with schizophrenia. It includes research I've been doing over many years, but I wanted to present it in a way that will have some relevance to people doing research or caring for older adults in general, not just those with schizophrenia. So I don't have any disclosure. So here are some of the topics I'm going to address today, or points I want to make today. I want to talk about changes that have occurred historically in how we view diagnostic criteria in schizophrenia, criteria for outcome, and the social factors that it might affect it. And again, I think this has relevance to many diagnoses we make in medicine. Comprehensive view of outcome should also include various symptoms, functionality, and combinations of these things, and even positive mental health. Again, how we define outcome and the rest of medicine is also relevant. We change it over time, and even the notion of positive health now emerges as an important topic. Outcome criteria, I'm going to point out, are largely independent of each other, and this is important in terms of how we care for people. Sometimes people think outcome in later life is very quiescent. This is especially so in schizophrenia, but again, in other areas of health as well, there's a tendency to think things are kind of chronic and not really studied very well and not being quite aware of what's going on. Moreover, outcome is often heterogeneous in later life. Again, as in rest of medicine, the outcomes of many illnesses vary quite substantially. One area I want to cover specifically today is the notion of recovery or recovering in schizophrenia and how we assess it, and how also it's variegated and it takes many forms. And as I said, point 7 is I want to show how this has relevance to other areas of medicine. So I'm going to move on. Any questions at this point? So just feel free to interrupt. There is a button, I think, for participants to raise their hand, but just interrupt, I think, will be fine. So first things I wanted to, since we're dealing with people from many different disciplines, I wanted to provide some preliminary points on schizophrenia and remind people what it is. The DSM-5 criteria say that you must have 2 or more of the following symptoms for at least 1 month or longer. And at least one of them must be from items 1, 2, or 3. So people must have either delusions, false beliefs that are beyond what most people would consider normal, hallucinations, typically auditory or visual, but it can also include tactile or smell, things with smell as well. Disorganized speech, sometimes we call that loosening of association, but thoughts don't hang together very well. People also with disorganized speech may often show disorganized behavior. And finally, we talk about negative symptoms. Sometimes we call them flattened affect. People don't show much emotionality. They often show apathy as well. Finally, it's important, and this is true of almost every diagnosis in the DSM manual, is that it has to include impairment in a major area of functioning. Typically work or interpersonal relations, self-care. And some of these signs of the disorder must be continuous for 6 months. And finally, there are other parts of this disorder many people feel are really part of the disorder itself, inherent to the disorder, deficits in cognition, often starting when the disease first takes place, its onset, and continues in later life, and also difficulties with mood. There are very high rates of depression among people with schizophrenia.
Can I ask a question?
Yes.
Yeah. So does the presence of an underlying like psychotic disorder like schizophrenia increase the risk of developing dementia in later life? And does it worsen the prognosis of dementia?
That's a topic in itself. Is not clear if it increases the risk of Alzheimer's disease, for example, but it very well may increase the risk of vascular dementia. Certainly, the studies have found that there are higher rates of dementia in people with schizophrenia as they get older. But it's a complicated picture because people have cognitive problems starting out in early life. And then as they age, they show a decline. No, they don't show a rapid decline as they age. Though some subgroups, perhaps those who have been long-term institutionalized or whatever, seem to show more rapid decline after age 65. So I'm giving you a very long-winded answer to suggest that they're going to show cognitive impairments in part because they have a disorder that as they get older, they may fall into the dementia category, but they're not truly a dementia as we think of it, like Alzheimer's. But they also may have an increased risk for other dementias, such as vascular, maybe Alzheimer's as well. We don't really know. So,
and does treatment with antipsychotics worsen like possibly like an underlying cognitive disorder?
You know, there's again debates about that, and there's not strong evidence that it does. Though we do see changes in the brain in people who are on antipsychotics for long periods of time. But it's not clear if it would do that, and the data aren't really clear that long-term use of antipsychotics increases the risk of dementia. But data aren't so clear on a number of things, and it needs to be studied. I might add, and I'll get to it on the next few slides. Let me move on. First, let me just say the reason people are going to should be concerned about older adults with schizophrenia is that it's an expensive disorder to treat. This is an old slide, but you can see as people get into their 60s and 70s, the cost of caring for somebody with schizophrenia is actually higher than even people with dementia, and certainly people with other medical disorders, because they're two serious illnesses side by side. And again, because they probably carry some cognitive deficits, they carry the symptoms of schizophrenia, and they often have higher rates of various medical problems, they become much more expensive to care for. Now, schizophrenia typically develops in the second or third decade of life. About a fifth to a quarter of people develop it before the age of 40. And the estimates place the number of people with schizophrenia prevalence rates about 0.6% to 1% people age 45 and over, and 0.1% to 0.5% in people age 65 and over. And why is the big difference is that people with schizophrenia have a 10 to 20 year gap in life expectancy, due primarily to poor physical health, although suicide rates are also higher, especially in younger life, but even it extends even to later life. So again, they're a red flag when anybody with schizophrenia walks into your office. They potentially have a number of health risks that you need to address. Now, finally, I just want to say that the age of demarcation is an important question, and it also relates back to the question of dementia. Before the age of 40, that's when about 3/4 of the people develop schizophrenia. We sometimes call it early onset schizophrenia. This is not a DSM category, but a work group established some of these categories quite a number of years ago, and it seems pretty relevant to what we see. Between age 40 and 60, we call it late onset schizophrenia. That's about a fifth of the people. And they look kind of similar to the early onset schizophrenia, but there are some differences, which I'll show in the next slide. And finally, there's a group age 60 and over, very late onset schizophrenia-like psychosis, which really suggests more of a neurodegenerative disorder. And people show more brain abnormalities and neuropsychological deficits. They seem more apt to develop dementia. There probably is something going on underneath. It's often difficult to differentiate these people from early onset dementia. It becomes a diagnostic challenge. So this slide briefly just summarizes some of the differences that you see. So those before 40, men are actually higher rates than women, especially those who develop the disease before the age of 30. And they tend to show a lot of the positive symptoms: hallucinations, delusions, disorganized thinking or behavior. They show more, the deficits of presentation are generally stable over time, though I'm going to question that to some extent with some of the things I'm going to show you. But the cognitive problems, as I said, start in the beginning, they do tend to decline over time, but more an age-related effect than a sudden decline. The people with late onset schizophrenia, the 40 to 60-year-old group, look similar to the early onset in many ways, perhaps not as quite prominent positive symptoms. Most notably, females outnumber males. They also may have some cognitive deficits. And the very late onset, over 60, they're much more apt to show visual or tactile hallucinations, physical delusions about having diseases, not as much positive symptoms, and they don't show the negative symptoms or the disorganized thinking that you typically see in some of the early onset cases. And their cognitive decline often does increase dramatically over time. In terms of treatment, the dosing tends to be the highest doses of antipsychotics in the early onset group, sort of medium range doses in the late onset group, and then very low, much lower doses. They just need a tiny bit in the very late onset group. So that gives you some picture of what we're talking about. Now I'm going to go on to the gist of the talk. I wanted to first suggest that outcome changes historically in schizophrenia, but I also, again, want you to think about it for the rest of medicine as well. This is a slide that shows you what's seen as either remission or recovery over time. And you can see early in the 20th century, it was thought to have a very dismal prognosis with respect to schizophrenia. Many of the people were in institutions, and it's hard to say how much the institutions contributed to that. Moreover, there was a tendency, many of you probably have heard the term dementia precox by Kraepelin. So the argument was you might not have schizophrenia or dementia precox if you improved. So it was a self-fulfilling prophecy. Only those people who didn't improve would be considered to have the disorder. By the mid-30s and 40s, there was a little bit more of a change in diagnostic criteria. There was a loosening up of criteria. We tended probably to include more bipolars in some of these diagnostic criteria. Also, Richard Warner wrote an interesting piece talking about how economic times improved outcome. When we were having, people were working and economics were good. You can see that in the 60s as well, which was the economy was doing well. People had a marked better view of what would happen with people with schizophrenia. They were, and indeed in the 60s, people started to get discharged from hospitals and put into the community. By the 80s and 90s, we developed a new diagnostic criteria, and the DSM went from a very simple manual to much stringent criteria of schizophrenia, and the prognosis seemed to decline. It might also have to do with cutbacks and funding and things of that nature, lack of housing, a whole bunch of failures in the discharge of people with severe mental illness. Now, what about older adults with schizophrenia? Again, we see a change from poor prognosis to more optimistic view. However, we've had to modify that with some of the longitudinal data we've been accumulating in recent years. Consequently, people in the 1900s to 1986, we thought maybe about 15% would go into remission. By mid-80s to fairly recently, we were saying about 50% were going into remission. But then these studies were based on snapshots in time. They were taken cross-sectionally, and people looked like they were doing a lot better than it turns out they were doing, because when you followed people over time, as we began to do, and a couple of other sites have now looked at, the prognosis was not as good. And about a quarter of the people showed remission. And I'll get into what remission is exactly in a minute. So the next point is, any questions at this point? I just want to interrupt for a second. All right, so I'll move on. So in terms of outcome, again, this is relevant to all of medicine. How we determine what an outcome is in a particular health problem is important. In schizophrenia, people decided symptoms are important, especially the positive and negative symptoms we talked about: hallucinations, delusions, the blunting of affect, functionality, again, a DSM criteria, how people function. Certainly in medicine, we're concerned about functionality in general. We wouldn't care about most medical problems if people function well with them. It's only when they're not functioning that it becomes a problem. Some of us have now looked at what we call recovery, where we combine both symptoms and functionality. So for somebody to be fully recovered, we'd want them to have an absence of symptoms and be fairly high functioning. And finally, positive mental health, which I'm not going to get into much today, but what you might call successful aging, where people are showing optimal physical health, cognitive health, social well-being. And it's very low in schizophrenia, as you might expect. But even in the general aging population, it's probably only about 20% achieve what some people call positive mental health or successful aging. So in terms of symptom outcomes, remission is one of the criteria I'm going to look at today. And then again, that's a reduction in symptoms such as positive and negative symptoms. Depression is another symptom to look at, and cognitive functioning. I indicated before, depression and cognitive functioning are probably part of the disorder itself. Social functioning, what I'm going to look at specifically today is community of social integration, where how people, their well-being in the community, their social interactions. It's a kind of conglomerate term of several aspects of how people are functioning. Of course, nowadays with COVID, a lot of people wouldn't do very well on the community integration scale. Also, other people look at instrumental activities of daily living and quality of life. Things of that nature can also be considered part of social functioning. I just want to say a word of how we derive the sample I'm talking about today. I don't want to belabor it too much, but we studied 249 persons who were 55 and over with early onset schizophrenia spectrum disorder. That means they either had schizophrenia or schizoaffective disorder. And they developed the disease before the age of 45, so they were early onset disorder. And they were living in New York City. And 38% were living on their own independently, and about 3/5 were living in various supported residences. And the mean age was 61. We were able to re-interview, determine the status of 162 of these people on follow-up 4 years later, a little over 4 years later, and we were able to re-interview 104 of them. And I'll be talking about some of that data as well. Most of the people re-interviewed were re-interviewed between 40 and 60 months later, though there were some outliers. So one of the things I wanted to point out, again, when one sets up outcome criteria, is that they can often be independent of each other. And that's good in many ways, because if you're going to create outcome criteria, if they're all measuring the same things, you're not really saying very much. They're basically the same measure. So we did find, for example, that remission, again, the elimination or marked decline in positive symptoms and negative symptoms, didn't correlate that highly at time 1 or 2 with community integration, didn't correlate that highly with the CSD, which is a scale for depression, and correlated relatively modestly with the Dementia Rating Scale, which is a measure of cognitive functioning. And you can look across this whole scale, you can see that the correlations range from 0 to 0.47. But even 0.47, well, I shouldn't even include that one because that's correlating. No, I'm sorry, that's correct, 0.47. But even that is what we call shared variance, is how much they overlap with each other. It's only 22%. Variance is determined by multiplying the squaring the correlations. That's how it's calculated. So there's still almost 80% of the variance is not explained by their relationships. So they're pretty independent of each other. So the good news is that they're good, legitimate outcome indicators. On the other hand, it shows that treating one of these outcome measures may not have as much impact on the other outcome measures. So we may have to work with them independently and find different strategies for treating them. Any questions there? Okay, I'll continue then. Maybe I put everyone to sleep. I don't know. Now, outcome is not quiescent or stable in later life, but continues to evolve. Again, this is a point which is relevant to medicine as well as our particular topic we're examining today. These are some, this one and the next slide I'm about to show are typical of what you see in the literature on schizophrenia, and it's only beginning to change, partially due to some of the work of myself and other colleagues. It was thought that everything happens in schizophrenia in early life and maybe a little bit in midlife, but then nothing much changes in later life. So this slide is even more obvious, where you can see that there's a little bits of deterioration in the 30s and then pretty much stable. Somebody drew a little blips here, but they're basically suggesting that nothing changes much as people get into their 40s and 50s. And this is not a correct way of viewing things. What we found here, and let me unpack this slide for you, is that we examined people over time, 52 months, and there were some people who were never in remission, never in high community integration, never attained recovery, never attained normal cognition, and never depressed. And you can see those range from about 18% up to 44% as you go down this column. And on the other hand, there was a group I've already alluded to, like the remission group, who was about 25% remained in a remission at both points in time. And this number was about similar for community integration, not so much for recovery, which I'll get to later. Normal cognition, there was about 43% who always had pretty good cognition, and 30%, and that's not very high number, as you can see, that we're always not depressed or we're not non-depressed. But what you can also see in the middle, there's somewhere between a third to 2/5 of people in most cases that seem to be moving between categories. And these are people who, again, if you read the textbooks from a number of years ago, people would have thought nothing's happening with them, but actually quite a bit is happening with them. And in the reasons that we in geriatric psychiatry continuing to see people and have to be vigilant. And again, as a point in medicine too, people who you think are chronic, if you actually follow them longitudinally, you'll be surprised how much movement there is. Now, the next point I wanted to make, outcome is heterogeneous with respect to these various outcome measures. One of the things, and this applies to people in general, is this notion of paradoxical aging. This is, in older people in general will show some decline in physical health and cognition. But there seems to be, as we study older people, many of them report their quality of life is pretty good. They seem happier. They're functioning better in many ways. And you might think it's kind of paradoxical because you think people might feel more depressed and report worse quality of life. Perhaps older people are more optimistic about things. The paradox may be more pronounced in older adults with schizophrenia. There are higher rates of mortality and physical disease in this group, in tandem with a trend towards fewer relapses, higher rates of clinical remission, and better self-management. So the argument is, again, here, people with schizophrenia are even showing a greater paradox. But I will argue that this is more nuanced because of heterogeneity in outcome. So what can you see from this slide is if you look at people who are persistently unfavorable outcomes and became worse over time in our 52-month follow-up, it was roughly half of people for remission, community integration, depression, even cognitive functioning getting close to half, and self-health, which we didn't have an actual measure of physical health, that we did have a number of physical disorders. But self-health actually correlates fairly well with people's real health. Anyways, about 36% we thought to be getting worse or unfavorable. And then you can see on the other side, the people who seem to be persistently in this favorable category got better over time. Now, when you see who does what, you can see from this slide, those people who were in favorable categories getting better or remain favorable over time was about 5-6% of the group. But there was a big group in the middle with four people, about 20% of people met four or more of these categories. Nearly a quarter met 3 or more of these categories, and over 1/5 of them met 2 or more. And down on the end, there were people, nearly 10%, who didn't meet any of the categories. So this notion of paradoxical aging is not quite true. There are some people who are doing well on everything, and there are people who are doing worse on some things, and then there are people who are good on some of them and not so good on others. Any questions there? Okay.
No questions in the chat as of now.
Okay, I hope everybody's not dead, but all right. Now, this is I wanted to give you a little work we're doing recently on what we call recovery or recovering. I'll try to be reasonably brief about it. You're probably familiar with the term recovery, if not from mental health, then from also working with people who might have alcohol and drug problems. And indeed, mental health people borrow this term from substance abuse people. You can take a cynical view of this. People who are alcohol or drug are never thought to be fully recovered exactly. They're always recovering. And that's because there's a tendency they could relapse. So the people in psychiatry, looking mostly at younger populations, they really didn't look at older adults, were saying, well, patients we're seeing are recovering. They're in recovery. They're working towards getting better. They're setting goals for themselves. Sometimes they relapse and then they go back on their track to recovery again. And it had a promising ring. It also made it more optimistic, perhaps more optimistic than was realistic, but it was a way to kind of save face on the fact that not always all our patients were doing especially well. So that's kind of more cynical view of it. So again, it's a critical component we see in psychiatry, and it's been dichotomized into a consumer construct, and that's the one I've been sort of presenting now, more personal, subjective. And then there's a clinical construct, which is more objective and clinical recovery. So let me give you an example. Consumer definition is a process of change through which individuals improve through their health and wellness, live a self-directed life, and strive to reach their full potential. So it's a process. It's an ongoing process of change, and they haven't necessarily reached full wellness and health. And people have pointed out, Bob Lieberman being one of them, has talked about this consumer model blurs the boundaries between those persons who are dependent and disabled and those who've actually achieved relatively normal mental and social functioning. So everybody's lumped into recovery, but yet there are some people who are doing really quite well. And then there are others who really aren't doing so well, but we're saying they're still in recovery. So the consumer construct is more akin to recovering, and it's a process and people are getting better. But what we really might want to know is who's recovered. So the clinical definition of recovery is one where symptoms and functions are actually reached a point where people no longer have are actually have minimal symptoms and are functioning pretty well. So that's what I wanted to look at, the clinical definition. So when I defined it as symptom remission, people would I already talked about symptom remission, that people have few or minimal positive or negative symptoms. And then they have functional remission, that they're community integrated, that their quality of life is good in the community, they have friends, they seem to be functioning pretty well versus their age peers. So this is what we found. If you look, and let me try to, again, unpack this in some way. If you look at clinical remission, we found roughly half of people on analysis were in clinical remission. But when you looked longitudinally, they were only 25% in clinical remission. And when we looked at community integration or social normalization, 37% were attained that cross-sectionally, and only, again, about a quarter longitudinally. If you combine them into one group who's actually community integrated and clinically in remission, almost a quarter of them at one point in time, a snapshot version, are in clinical recovery. But over time, fewer than 1 in 8, or roughly 1 in 8, are in clinical recovery, 12%. And just as a point of, I mentioned it before, if you want to look at successful age, your positive mental health, it was only about 2%. So what does this mean? First of all, our 22% cross-sectionally was worse than about the 13.5% that some people have found in younger samples. And it was also higher than other people have found with some older adults with schizophrenia. However, if you look at our longitudinal studies, it looks pretty similar to the literature. Now, the literature with older adults was cross-sectional, but with the younger population, it tended to be somewhat longitudinal in nature. Problem with all these issues of recovery is that there are geographical differences, how long stability, what counts for recovery in terms of stability. So the review of the literature shows you how wide range it is. And the results went from 0 to 58% based on a minimum of 2 years or more of stability. So there's really a contested area here in what counts for recovery and who gets there. Just quickly, we couldn't do this for our longitudinal data, but cross-sectionally, we found depression and anxiety were potential predictors of who actually attained clinical recovery. And this came from many variables that we looked at, including a variety of demographic variables, coping style, how people deal with conflicts, religiosity, influence by therapists on their medication, side effects. So it's hard to really come up with good predictors of clinical recovery, and a lot of work needs to be done there. I'm going to skip over that stuff. So how do you look at clinical recovery over time? So what we found, again, is, I guess there are lumpers and splitters. I've become a splitter here. And recovery in old adults with schizophrenia is not simple. We see that there are actually 5 groups that manifest themselves. So we have the tier 1, the premium platinum group, 12%. That's the ones who I pointed out have persistently recovered over time, at least over 4.5 years. And this seems to be a stable state for them. For them, it's a legitimate state. Now, what's the treatment approach with this group? One could argue, keep them on whatever they're on, they're doing great. And whatever therapy you're doing, continue doing that. The other possibility is this a group where you may be able to lower their medication or perhaps discontinue their medication. There is some evidence that some people with schizophrenia over time can actually do quite well if they discontinue the medication. Then there's a tier 2 group, not quite the platinum group, but this represents another 23% of people who fluctuated between recovery and non-recovery. That was what I was pointing out before, movement between groups. And so at one point in time they were recovered, at another point in time they didn't achieve that. So one might suggest or argue that with appropriate interventions, these people might be able to attain persistent clinical recovery. So perhaps focusing a little more on the symptom part might get them into full recovery, or perhaps focusing more on the social deficits they may still be experiencing might get them into full recovery. And this is a fluctuating state. And then there's a tier 3 group, kind of mid-group. It's a stable state where persistent clinical remission is attained. So they're able to achieve one aspect of recovery, but they're never able to attain community integration, or the obverse of that, where they can attain persistent community integration, but not attain clinical remission. Again, these people might benefit from more targeted approach to their clinical and social deficits. Now there's a lower group, tier 4, and represented close to 2/5 of people. And again, a fluctuating state where they're able to attain some clinical remission. Sometimes they can obtain community integration, but usually only at one point in time. And clearly they need more intensive work, and at both clinical and social levels, either both medication and a lot of perhaps day programs, social interventions of various sorts. And finally, there's a stable state, but a state that's not so good with the 18%. And this is the people who haven't gotten the platinum, the gold. They're not the elite flyers. They're not the service people. They're not whatever. They're just the ones who get on the plane last. And they're not considered, they might not even be considered recovering. I know you may use the term for them, but they haven't either attained clinical remission or community integration at any point in time. Clearly, they may require the most intensive interventions of all. So to summarize up here, slightly over 1/5 of older adults with schizophrenia met criteria for clinical recovery as single point, or only half of these people met criteria for persistent clinical recovery on 52-month follow-up. The majority of people were in varying states of recovery, in which they were in clinical recovery only part of the time, or met only some of the criteria for clinical recovery, such as clinical remission or social recovery. And we identified 5 tiers within recovering, for which different treatment strategies might be appropriate. In so doing, we suggest that we provided some provisional empirical grounding for what a lot of people have been terming recovery in the literature. But it's a much more nuanced state. And we suggested perhaps that depression and anxiety might be targets for helping to achieve recovery, but longitudinal studies are needed. So here are some take-home points. And so the definitions of outcome measures can vary and affect findings between studies, and they need to be validated by age and culture. There may be historical differences in outcome related to clinical criteria, social, historical, and environmental factors. Cross-sectional data, while they're nice to have, we should be very wary of them. They only provide snapshots, and they really don't tell us much about change, which is very important with all people, and more so perhaps with older adults. It tells us nothing about causal relationships. And many disorders are heterogeneous with respect to outcome. It is not easy to predict course over time. So we really don't know where people are going to end up. Even in later life, you could see there's a lot of fluctuation going on, and interventions are still warranted. And old age is not necessarily a quite quiescent period for people. And we have to remember that for all illnesses that we're treating, that people with long-standing illnesses often are affected by various biological, psychological, and social factors that can impinge on their illness. So I think with that, I'm finished with the slideshow.